we're going to cover a lot of different liver topics, and um, hopefully we can make some headway on some of the complexities in treating liver disease and especially in diagnosing it. A 44-year-old woman presents with a 4-week history of anorexia, nausea, and abdominal pain. She stopped drinking alcohol 2 weeks ago because she felt too sick to drink. It's never a good sign. Past medical history: alcohol abuse for 24 years, depression, hypothyroidism. She's on fluoxetine and levothyroxine. She's febrile, tachycardic, blood pressure is 90/60. She's got icteric sclera. She's jaundiced, looking at her skin, spider angioma present. She has a large liver, which is tender, trace edema. She's oriented ×2, does not have any asterixis. Her labs: AST of 100, ALT of 35, ALK Phos of 200. Her total bili is 40.9 with a direct bili of 19. Her albumin is 2.6. INR is 2.4. Platelets are 90. Hematocrit is 35. White count 11.2. MCV is elevated. What is the most likely diagnosis for her? Autoimmune hepatitis, PBC, drug-induced liver injury, Budd-Chiari syndrome, alcoholic hepatitis, or acute cholecystitis. Yes, in this patient who has a heavy alcohol history and has an AST, almost 3 times what her ALT is, she has severe alcoholic hepatitis. So absolutely. Questions are going to get harder. Um, the general consensus on this is we think about this when the AST to ALT ratio is greater than 2 to 1. ALTs tend to stay normal with alcoholic hepatitis. So we can get severe alcoholic hepatitis with ratios of 3 or 4 to 1 with individuals who have a AST of 90 to 100. Interestingly, it's the opposite for viral hepatitis, where the ALT is generally higher than the AST until patients get cirrhosis, at which time that ratio rises to 1, or the AST then becomes slightly higher than the ALT after cirrhosis in people with viral hepatitis. Okay, thinking back to this woman who has the severe alcoholic hepatitis, what might improve survival? Cyclosporin, propylthiouracil, protein restriction, corticosteroids, or antibiotics? Yes, this patient meets criteria for giving corticosteroids, so that would be an appropriate thing to do. She has low platelet count, very, very high bilirubin, um, multiple things. She also is not actively GI bleeding, and she does not appear to be infected. We didn't give a local source of infection that would be a reason not to give steroids. When we look at the survival benefit at 1 and 6 months in patients who have a discriminative function of over 90, and she's well over 90, who received 40 milligrams of prednisone for 4 weeks, you can see this pretty big difference. You see that at 24 days you're at 70% survival versus 94%, and the plateau in survivability up high over 90% in individuals who get steroids. The best thing we can do, though, to keep people alive with alcoholic hepatitis is the most obvious thing, which is abstinence from alcohol. And you look at the 1 and 2 year survival rate for people that are abstinent versus people that are hospitalized with severe alcoholic hepatitis. Their 1 and 2 year survival rate is only 10% for individuals at 2 years who are non-abstinent, 20% at 1 year. So this is certainly the single most important thing to do. A 51-year-old man presents with increasing pain in his hands. He's found it harder to keep working at his job as a mechanic. Past medical history: diabetes, hypertension, and hyperlipidemia. He has a distant history of nasal cocaine use. On exam, he has swelling over the metacarpal phalangeal joints of his hands. Hemoglobin is 14, hematocrit's 42, ALT is 66, AST is 100. Albumin is 3, and I'll show you his hand film. So he's having hand pain. That's why he's come in. But he's got diabetes, hypertension, hyperlipidemia. He's got some lab abnormalities with ALT of 66, AST of 100, and a low albumin. Here are his hand films. What is the most likely diagnosis? Alcoholism, hepatitis C, porphyria cutaneous tarda, hemochromatosis, or sarcoid. So which of these is the most likely diagnosis? Okay, so most of you chose hemochromatosis. Absolutely correct. And the hand pain with with osteoarthritis in the MCP joints is very classic for this. Most people get DIP and PIP joint osteoarthritis, and they don't get it proximal to that in the hands. And so it's very odd at this age, really any age, to have the pattern that this individual has, and that should make you think of hemochromatosis. He also has elevated transaminases, he has diabetes, so he has other things that would make you think about it. So when we're trying to diagnose hemochromatosis on the boards, look for funny arthritis involving the metacarpal phalangeal joints of the hand. Diabetes may have a cardiomyopathy. Liver issues. Hypogonadism is another important clinical feature that occurs in individuals, especially men with hemochromatosis. And I mentioned be aware of the patient with alcoholic cardiomyopathy, because it's easy to ascribe cardiomyopathy to somebody who's had long-term heavy alcohol use, but alcohol also increases in these patients. They get a heavy iron load, so they can definitely develop cardiomyopathy from the hemochromatosis a little earlier in life. So you look at the areas that are heavily involved here in these metacarpal phalangeal joints. Classic presentation is bronze diabetes. You have to be able to recognize the skin discoloration. Often patients don't pick up on it, and actually physicians don't very frequently either. More important to find the other features. Most patients are tired, cardiomyopathy and liver disease, 75%, hypogonadism in almost half. And the pearl here is that men have small testes with their hypogonadism, whereas hypogonadism from other forms that aren't occurring from a pituitary cause, the testes will not shrink. Arthritis in almost half, and then 70% may have an odd skin color, half have diabetes. The best screening test is an iron and TIBC. So that's been purported as, if we're going to population screen, look for a very high iron saturation is a wonderful screening test. Ferritin we will check, but ferritin can go up in inflammatory states. So the iron TIBC is a little better screening test. Diagnosis, liver biopsy, genetic testing, and the treatment is still phlebotomy. 35-year-old man is denied life insurance due to an increase in liver enzymes. He feels well with no symptoms. Past medical history, no significant past medical history. He's not on any medications. Family history is negative. He reports 3 glasses of wine a day, no tobacco use. Blood pressure 120/80, pulse is 50, BMI 23.9. Exam is no abnormalities. You repeat his blood work, and his AST is 68, his ALT is 70, alk phos is normal, bilirubin is normal. What is the most appropriate management? Remember, this guy was denied a life insurance policy because he had elevated transaminases, and now he's coming to get those worked up. What is the most appropriate management? Ultrasound, CT scan, liver biopsy, repeat in 1 to 2 months after abstinence, or you don't need to do anything. These aren't really bad liver tests. Okay, so half of you want to do an ultrasound, half of you want to have him be abstinent for a month. I would probably go with the abstinence. He is drinking he's reporting 3 drinks a night, maybe more than that. And I'd like to see what happens when I have 4 weeks, zero alcohol before I embark on a workup here. So that's what we're going to do. And he signs up for that. He's not going to have that. He's going to do it and come back in. And so he does do it and comes back in. And we'll talk about that in a second. Anyway, the first step in evaluating liver enzymes is discontinue all alcohol. And if there's any supplements or any medications that are known to cause transaminase elevation, do a brief discontinuation off them and see if everything normalizes. We don't want to ever ignore abnormal liver enzymes because the severity of the elevation is not predictive of whether cirrhosis is going to develop. And this is especially true with MASLD, where we have these lots of patients who have fatty livers, and some of those with mild elevations can progress. So we always want to do a workup, but the first step is to get rid of all toxins and then retest. So he does it. He's very good about that. He returns in 2 months. AST is 55, ALT is 78, ALT phos is 109, bilirubin's 0.8. Now you go ahead and get a little more history, and you ask him again, and now he shares something he didn't do before. He shares that in his 20s he was an injection drug user for about a year. What are your next tests now with this information? An ultrasound, a CT scan, Hep C, Hep B serologies, Hep C PCR, Hep B PCR. Yeah, we want to get a hepatitis C and Hep B serologies. We want to first see if he's Hep C positive, Hep B positive, more likely to be Hep C positive with that history. That a year of injection drug use back in the 70s or 80s, very high likelihood of hepatitis C. So we're going to go ahead and get that as our first test. Most people now will get that with a reflex PCR if it's positive. So this patient's history and labs now are most consistent with a viral hepatitis. Ultrasound and CT is probably not very helpful early in the diagnosis of transaminases elevation unless you are certain that it's fatty liver because of all of their clinical features. Usually we're going to go ahead and do some of the serologic testing first. And so we go ahead and do that with him. So let's go through a step-by-step workup of elevated transaminases. Step one, we talked about stop all alcohol, stop all drugs and supplements that have been tied to bumping liver enzymes. And that may include stopping a statin for a week or two just to show that the transaminases may be due to the statin. Step two, test for Hep B or C, hemochromatosis, checking an iron TIBC, and then consider an ultrasound looking for NASH. Step three, consider non-hepatic causes if all the testing we've done are negative. Step four, we look for some of the liver zebras. And then step five, when all the tests are negative, then we can do watchful waiting if the transaminases are less than 2 times upper limit of normal, and we will do a biopsy if persistently positive or if they're higher than that. So what are some of the non-hepatic causes of increased transaminases? We threw that into the algorithm there. Muscle disorders. Remember that muscle has a lot of AST, so people that have polymyositis, people that have had rhabdomyolysis, muscle injury, may get a high AST. Most of them will not have much of an elevation of ALT. Thyroid disorders, individuals with a low with a very high TSH, with hypothyroidism, they can get protein aminoglycan infiltration in the muscles, which can raise AST levels. Celiac disease has been associated with isolated ALT elevation, and tends to get better when they go on a gluten-free diet. Patients with adrenal insufficiency can have transaminase elevation, and individuals with anorexia nervosa for several reasons, including muscle breakdown. So follow up on this patient. He gets his testing. Hepatitis B surface antigen is negative. Hepatitis B B surface antibody is positive, core is positive, hepatitis C is positive. Interpretation, chronic hep B and chronic hep C, chronic hep B and past hep C, past hep B and past hep C, or past hep B and probable hepatitis C. So which is the correct interpretation of these? Okay, so most of you picked D, which I think is the correct answer. He's Hep B surface antigen negative. He's got antibodies to suggest past Hep B infection. He has positive Hep C antibody. So, given his injection drug use history, it's almost certain he's going to have a positive Hep C virus with his transaminase elevation when we test for that. But this person has past Hep B, very probable Hep C. So when if you do a ELISA based test for hep C in low risk populations, you end up having a fairly low sensitivity in low risk populations. Fortunately, now we have reflex testing and we can get this information very, very, very quickly. But be aware that before you give information for either hep B or hep C to patients from very low risk populations, you want to confirm it, because the false positive rate, although low, is very high in a very low risk population compared to the true positive rate. So once we get the positive hep C antibody, we're going to do the viral load measurement. Now, this is information that's super important. And we talked about this in patients with alcoholic hepatitis, that the best thing you can do is get people to stop drinking. It's also the same thing you can do in patients with hepatitis C, that even moderate drinking can really increase the risk of fibrosis happening with hep C. And certainly heavy drinking can be a major problem. So you can look here, the relative risk of fibrosis in individuals who are teetotalers, who are hep C negative, is 1. An alcohol abuser, it's 15-fold. Now you look at a hep C positive person, the teetotaler, they have a 9-fold increased risk of developing cirrhosis, but if they're abusing alcohol, it's 147-fold increased risk. So you see how dramatic alcohol multiplies against hep C positivity. So I wanted to show a couple of the extrahepatic manifestations of hep C. This is a leukocytoclastic vasculitis that can occur in patients with hepatitis C. Fortunately, this also gets better when we treat hep C. A few more pearls about hep C, and this is something that changes so rapidly. I don't think they're going to ask you about active treatment. They're going to ask you, do you treat or don't you treat? I don't think they're going to ask you which of the combinations you're going to use, because these do change every year to 18 months, and the questions are much longer. So this is just for your reference, but this stuff changes so quickly, it's not going to be asked on the boards. Now let's move on to some of the more bread and butter things you all have so much experience with, which is managing some of the complications of managing our patients who have end-stage liver disease. A 47-year-old man with end-stage liver disease presents for evaluation. He has a history of MI and has osteoarthritis and gout. Which of these medicines should be avoided in this patient? So which would be the most dangerous medicine for this patient? Statins, NSAIDs, acetaminophen, or prednisone? Which of these is the most dangerous drug to put this patient on? Okay, very good. So people don't want to give NSAIDs, absolutely correct. So NSAIDs are the most deadly problem here because this patient has end-stage liver disease. This person's his volume status, his renal status is going to be really touch and go, and throwing an NSAID onto it may cause renal dysfunction, potentially could make hepatorenal syndrome a thing. And then the other thing is this person's at high risk for GI bleeding with NSAIDs. So we want to avoid NSAIDs. Statins actually might have a slight positive effect in this patient in regards to their liver disease outcomes. And acetaminophen, we certainly don't want to give them high doses of acetaminophen, but doses under 2 grams a day should be safe. Prednisone should have no problem. So acetaminophen okay up to 2 grams, statins may be beneficial, and NSAID should not be used. 45-year-old man with end-stage liver disease presents with abdominal pain. On exam, he has temperature of 38.3, a pulse of 100, a blood pressure of 90/60, abdomen with shifting dullness, ascites on handheld ultrasound. He's tender to palpation and with shaking the abdomen. His white count is 14,000. Sodium is 128, albumin is 2.3, creatinine 1.2, bilirubin 4.4. A paracentesis is done with white count of 1,000 with 80% polys and very low albumin. What do you recommend in this patient? Ampicillin and tobra, levofloxacin, cefotaxime and albumin, levofloxacin and metronidazole, or ceftriaxone. So which of these would be the best treatment for this patient? So this is a little bit of a tricky question. I mean, I think that the answer is the right answer, but many of you probably don't have a lot of experience using cefotaxime. If you look in the guidelines, cefotaxime is a recommended drug because it has the best data for SBP. The studies were done in the 1980s when cefotaxime was a standard drug used, and it was sort of the best third generation we had. Currently, we don't use it very much anymore. So some of you are like, well, I'm just going to go to ceftriaxone because that's what I use. Ceftriaxone is an outstanding choice here. The only problem is we want to give this person albumin as well. So we need to give a choice that gives a good antibiotic and also gives albumin. And cefotaxime is a first-line antibiotic and the albumin. This person has indications for albumin that would possibly reduce the mortality. So just some pearls on SBP. It's more common in patients with ascites who have high SAGs. So they have a big gap between the amount of protein that's in their paracentesis fluid and in their blood. These patients with liver disease generally have very low amount of protein in their paracentesis fluid, and that leads to low complement levels and low protection. So it makes SBP more common. Over 250 polys per microliter has a high sensitivity. Treatment of choice is cefotaxime or other third-generation cephalosporins for 5 days. And if their creatinine's over 1, bilirubin's over 4, BUN's over 30, then they should also get albumin on days 1 and 3. That's been shown to decrease in-hospital mortality. One thing, some people chose levofloxacin and metronidazole. For SBP, we really don't need anaerobic coverage. They do not tend to get anaerobes because it's not a hospitable environment. If you rupture your colon into ascites, then anaerobes may be problematic, but not something we need to cover for SBP. A 44-year-old woman with end-stage renal disease and refractory ascites and esophageal varices on EGD 6 months ago presents for follow-up. She has been receiving large volume paracentesis weekly for 6 weeks to try to manage her ascites. Her meds are Cipro, 750 milligrams weekly, propranolol, 10 milligrams twice a day, vitamin D, sodium's 128, albumin's 2.4, peritoneal fluid, total protein 1.1, blood pressure is 88 systolic, pulse is 66. What do you recommend for her? Do you stop her ciprofloxacin? Do you increase her Cipro to 500 milligrams daily? Do you increase her propranolol 20 milligrams BID, or do you stop her propranolol? So I agree. I think we should stop the propranolol. Propranolol is a helpful drug in the right setting, but in patients who have more advanced liver disease, and especially in the setting where they have multiple risk factors, including elevated creatinine, elevated BUN, hyponatremia, and very low total proteins, um, we need to give fluoroquinolones or we give something for SBP prophylaxis. But the beta blockers should be avoided in our patients with refractory ascites because that group has had increased mortality. So we want to do SBP prophylaxis in patients who have a number of risk factors, including the low uh, ascites total protein, and we want to use non-selective beta blockers until the patient gets refractory ascites. At that time, we will stop them. So definitely want to have a lot of our patients on SBP prophylaxis and beta blockers, but be ready to stop your beta blockers when they progress and their ascites is refractory. A 60-year-old woman with a history of end-stage liver disease presents with worsening confusion. She has a history of hepatic encephalopathy. Her family brings her in today because she has had 3 falls in the last 24 hours, including one this morning that was unwitnessed. Her daughter found her on the floor. Temperature is 36.6, pulse is 90, blood pressure is 90/60. She has jaundice, abdomen is soft, non-tender, no fluid wave is present, heme negative stool. White count is 6, hematocrit 44, B1 8, creatinine 0.8, has a normal urinalysis. So confused individual, history of hepatic encephalopathy, 3 falls in 24 hours, and was found on the floor with an unwitnessed fall. And you see her vital signs. She's confused. White count is 6. B1 creatinine are okay. Hematocrit's okay. UA is normal. What is the next most appropriate test? Abdominal CT scan, a non-contrast head CT, an ammonia level, liver function tests, or a D-dimer? Okay, I would, of this, in the person who has mental status change, multiple falls, unwitnessed, I would get, of these choices, I get a non-contrast head CT. The main point I want to make is ammonia levels are rarely of any benefit, and they're really not particularly helpful in individuals who have known hepatic encephalopathy. Um, it really isn't helpful to follow ammonia levels, and it's not going to give us our diagnosis. Very likely to be high, even if it's in the lower, just barely elevated. It's not going to tell us exactly what's going on with her encephalopathy. Obviously, in this setting, we're going to look very aggressively for an infection, SBP, very high risk for that. Certainly, possibly a pneumonia, aspiration pneumonia, or urinary tract infection. And then head CT if unwitnessed falls or head trauma. So if the patient's had a head trauma, then we're going to obviously do it. And if they've had an unwitnessed fall like this patient, it's reasonable to do it. These patients have a little higher risk of intracerebral bleeding. So just to recap here, I don't think on the boards choosing an ammonia level will be the right answer. And the head CT, if they have unwitnessed fall or if they've had a witnessed fall with trauma to the head. 57-year-old woman with end-stage liver disease due to hepatitis C presents for follow-up. She was last seen 2 years ago. What testing do you recommend for her? She's got end-stage liver disease. She has cirrhosis due to hep C. Last seen 2 years ago. What do we recommend for her? Hepatic ultrasound and alpha-fetoprotein, hepatic CT scan, LFTs and alpha-fetoprotein, or serum ammonia level. So yeah, I think I like that you're choosing A and B here. Um, Individuals should get a combination of ultrasound. That's super important in these individuals when we're screening for a hepatocellular carcinoma, and That should be done, reasonably every 6 months. A year is a long time to wait for this. Some patients who are sort of triaged into a little lower risk with their cirrhosis may go yearly, but most will get them every 6 months. Hepatitis B and C are the highest risk for hepatocellular carcinoma, but hemochromatosis has a significant risk for this, and it's seen with all forms of cirrhosis. We do not recommend doing alpha fetoprotein screening by itself. It's not sensitive enough. Um, we want to screen all patients with chronic hepatitis B. Um, if it's active, and then certainly Asian men over 40, there's a higher risk for hepatocellular carcinoma there, Asian women over 50, and African American men. So there's some risk groups that are higher risk, so we're going to do even more screening. A 50-year-old man with a history of alcoholism presents with severe right upper quadrant pain, nausea, and fever. AST is 45, ALT is 35, ALK phos is 200, white count is 17,000. Ultrasound shows 3 to 4 small gallstones, no pericolic fluid. So we got a person with right upper quadrant pain, fever, nausea, and he has been drinking heavily. AST is 45, ALT 35, high ALK phos, white count is high, and he's got some gallstones, but no pericolic fluid. So we're kind of in the limbo here a little bit. What additional test would best help in diagnosing acute cholecystitis in this patient? Abdominal CT scan, an abdominal MRI, a HIDA scan, bilirubin, or a liver spleen scan? Yeah, so this patient should have a HIDA scan. Um, we don't want to operate on somebody with alcoholic hepatitis. Because their risk of mortality is quite high with surgery. So we would want to be certain on any diagnosis we would make. So this patient doing a HIDA scan will separate out whether his fever, right upper quadrant pain, and symptoms are due to alcoholic hepatitis versus an active acute cholecystitis. So we don't use the HIDA scan very often. We use it for acute cholecystitis. It's also a good test for looking for acalculous cholecystitis. So our hospitalized patients who have right upper quadrant pain and look for all the world like gallbladder disease, but we image and it doesn't look all that exciting. The HIDA scan can be very helpful in them. A 54-year-old woman presents with severe abdominal pain for 2 hours. The pain came on suddenly and was 10 out of 10 in severity. It was in her right upper quadrant, radiating to her back. She has had a 50-pound weight loss in the last year. She is evaluated in the ED, and labs show an AST of 450, an ALT of 500, an ALK phos of 100, and a bilirubin of 1.2. She receives morphine for her pain with minimal relief. An ultrasound shows multiple gallstones but no dilated ducts. A HIDA scan shows no signs of acute cholecystitis. Her pain resolves 3 hours after arriving in the emergency department. Repeat labs 15 minutes after pain resolution. AST 900, ALT 1000, ALK phos 130, bilirubin 1.2. So somebody with really bad abdominal pain, 50-pound weight loss in the last year, you see these high AST and ALT. ALK phos is unremarkable. Bilirubin's not too remarkable. Minimal pain relief. Ultrasound shows gallstones. HIDA shows no acute cholecystitis. Pain goes away. Get labs 15 minutes after pain resolution. Oh my goodness, AST and ALT are even higher. ALK phos is minimally elevated. Bilirubin 1.2. What is most likely diagnosis? Acetaminophen toxicity, hepatitis A, ischemic hepatitis, a liver fluke, or passage of a gallstone. Okay, so you did well on this one, passage of a gallstone, and sometimes people get a little confused because we're taught in medical school that Alk Phos is kind of the obstruction lab, and it's a lab of chronic obstruction. What you see when you pass a gallstone is acute obstruction, and you're usually going to see a rapid rise in transaminases. So that can be confusing because it isn't often associated with a rapid rise in Alk Phos as well. After a while, the Alk Phos will start to go up. If somebody's obstructed for 2 or 3 days, or months on end in some of the diseases that cause obstruction, we see predominant alk phos elevation. But early on, we will see increased pressure in the parenchyma and elevation in the transaminases. So AST and ALT are elevated far greater than alk phos or bilirubin. Once the obstruction has persisted, then the alk phos goes up. GGT is probably our most sensitive test for any obstruction. And then the AST and ALT usually go down pretty quickly within about 24 hours after obstruction is released. A 46-year-old man presents with fatigue and pruritus, most prominently on his palms and soles. He's been more fatigued for the past 6 months. Past medical history, depression, GERD, ulcerative colitis with colectomy in 1998. Currently taking sertraline and omeprazole. Blood pressure is 100/60, pulse is 80, temperature 36.7. Eyes is sclerononicteric, abdomen, liver is 12 centimeters, splenomegaly is present, no fluid wave, no spider angioma or polymerythema. He's got excoriations on his arms from all his pruritus. So 46-year-old with itching. We see blood pressure 100/60, pulse of 80. He's got non-icteric sclera. He's got a big spleen, slightly enlarged liver, but a big spleen. We're going to give you some more data here in a second here. His labs is AST is 85, ALT is 90, alk phos is 600, bilirubin 19, albumin 3, INR 1.1, platelet count 120,000, BUN 15, creatinine 1, abdominal CT, small nodular liver, splenomegaly, abdominal varices are present. What is the most likely diagnosis? Chronic hepatitis C, primary sclerosing cholangitis, chronic hepatitis B, primary biliary cholangitis, or constrictive pericarditis. Which of these makes the most sense? Okay, so you did well on this one. So PSC, and really pretty much anybody with an ulcerative colitis history who comes in with a cholestatic picture, we got to be thinking about PSC. And the key pearl here is he had a colectomy, but colectomy does not protect you from PSC. So it can happen years later in individuals who have had colectomy. So the itchiness he had suggested cholestatic disease. It's more common in middle-aged men and very frequently associated with inflammatory bowel disease, more commonly ulcerative colitis, but be seen sometimes in Crohn's. What test would you do to confirm this diagnosis? You think it's PSC, what do you order? A liver biopsy, a HIDA scan, a hepatic ultrasound, or an endoscopic cholangiogram? Okay, so yes, endoscopic cholangiogram. We want to look at the pattern, and we'll see a very typical pattern for PSC with that. The liver biopsy will show that he probably has cirrhosis, but it's not going to give us a diagnosis of PSC. It's something we have to look on a larger scale to be able to see what's involved. So it's based on biochemical, clinical, and cholangiographic findings. What you will see, and you may see this reported in a study on the boards, multifocal strictures beading. So they got strictures with some dilation behind that. So most cases are in men, so up to 70%. Most have a history of inflammatory bowel disease. In Norway, 98% of people with PSC have a history of inflammatory bowel disease, down to a low of 36% in Italy. The US is kind of in the middle at 75%. 2.5 to 7.5% of people with inflammatory bowel disease will develop PSC. Cholestatic features are typical, positive ANCA 80%, and they usually have signs of chronic liver disease. How would you treat him? Ursodeoxycholic, colchicine, liver transplantation, or prednisone and azathioprine? So the only real effective treatment is liver transplantation. Ursodiol isn't going to change the outcome. I think Ursodiol you can try because he's itching so much. The effectiveness with this disease is small. I think that's reasonable. I think liver transplant is the long-term only thing that's got a long-term efficacy to it in this disease. So no therapy has had a major impact on survival. High dose ursodiol was disappointing in trials. So we're going to try to relieve symptoms and optimize timing for liver transplantation. Some of the complications you see with PSC, um, pruritus is super common. You can try naltrexone, you can try cholestyramine to help with that. They have high risk for getting bacterial cholangitis, so they need antibiotics, and a reasonable percent of people who die of this die from biliary sepsis. They can have fat soluble vitamin deficiency. Half of them have osteoporosis, so supplemental calcium, vitamin D, and bisphosphonates. They do develop cirrhosis and can have real trouble with GI bleeding. And then most dreaded complication, really cholangiocarcinoma, which has a very, very, very poor prognosis. A few comments about autoimmune hepatitis. It's most commonly seen in women, and it's really between the ages of 20 and 50, with a clustering probably between 30 and 45 is probably the peak incidence of this. Most of these patients have some other autoimmune disease. It might be type 1 diabetes, it might be thyroiditis and hypothyroidism, it might be ITP. Celiac disease also is not uncommon in these individuals. So it's not common to get autoimmune hepatitis with no other autoimmune diseases. So that's something you're going to look for in the stem. When you think about this diagnosis, do they have anything else autoimmune going on? Most of them have an abnormal SPEP. 97% of these patients will have a abnormal SPEP with hypergammaglobulinemia. Also, they have positive ANA with anti-smooth muscle antibody. These patients respond remarkably well to corticosteroids, azathioprine used as a steroid-sparing agent, often in combination with steroids, and can be very, very effective. And there are newer treatments, but that's still really the gold standard treatment. Couple of words about Wilson's disease, a very, very rare disease. The older your patient is, the less likely it is to be Wilson's disease. Remember, this is a genetic disease. Patients have it from birth. They do not tend to show symptoms until the teenage years into the 20s is kind of where you start to really see symptoms. But most people are going to be having symptoms by age 40. So having a 50 or 60-year-old with Wilson's disease would be extremely case report-ish. So on the boards, it's going to be in a younger individual. They get Kaiser-Fleischer rings, sunflower cataracts. The Kaiser-Fleischer rings are much better picked up with slit lamp exams than with the naked eye. They can get neuropsych problems like Parkinson-like tremor and clumsy gait. Hemolytic anemia can occur. Certainly, liver disease is very, very common. They can get chondrocalcinosis of the knees. As far as initial testing, getting a ceruloplasmin level, but also getting something to look at copper excretion, because ceruloplasmin levels can be falsely abnormal. They can be falsely low. So I think it's important to go ahead and get a 24-hour copper excretion as well. And slit lamp exam, if you can get it, to look for Kaiser-Fleischer rings. Okay, next case, a 54-year-old woman comes to you to establish care. She's very tired. She's had only a couple of symptoms, which are dry eyes and itchiness. Past history, hysterectomy for fibroids 10 years ago, no alcohol, tobacco, or drug use. So you have a new patient who's tired, like so many of our patients, itchy, and has dry eyes. You do an exam and you're surprised to see spider angioma in multiple places on her body. She's got a little bit of an enlarged spleen. The rest of her exam is normal. On her labs, you're struck with the how low her platelets are at 90,000. Alk Phos is 3 to 4 times the upper limit of normal. Bilirubin is 2, albumin is low at 3, INR is up at 1.6, and her TSH is 10. What is the most appropriate next step? An ultrasound, a CT scan, a liver biopsy, further laboratory testing, or symptomatic treatment for her eyes and her itchiness? So we all did well on this one. We want to get further lab tests. To make this diagnosis, we're going to do much better with lab results than a liver biopsy. Ultrasound, CT scan, liver biopsy are probably all going to show cirrhosis in her in some way or another. But the real question is, what do you think's going on with her? So um, when we see somebody with likely new cirrhosis, we're going to want to make sure that we look at different autoimmune diseases. We want to make sure that we're not missing hepatitis C. Imaging tests are going to show cirrhosis. We're going to make a diagnosis. And once you have cirrhosis, liver biopsy is not particularly necessary. The one time, you might be able to find high iron stores in a patient with hemochromatosis, but we can diagnose that without a liver biopsy. What is the most likely diagnosis in this patient? Chronic hepatitis C, primary sclerosing cholangitis, autoimmune hepatitis, primary biliary cholangitis, non-alcoholic fatty liver disease, or Wilson's disease. Which one of these do you think it is? So this one is very typical PBC. It's the right age for the patient. Itching, presenting with itching is very, very, very common. Dry eyes. Some of these patients also have Sjogren's syndrome as well. This patient has a high TSH, so probably has thyroid disease, has some autoimmune stuff in the background, and has an isolated, really, so it has liver disease, but it's predominantly an elevation in alkaline phosphatase. So all these things are features that are very, very consistent with PBC. We do further testing. Hepatitis A is negative, hepatitis B is negative, hep C is negative, ANA is negative, anti-smooth muscle antibody is negative. Her antimitochondrial antibody is very, very positive at 1 to 2560, normal iron studies. She's got splenomegaly, and nodular liver, portal hypertension. Uh, so she fits perfectly, and I want you to be aware of that positive antimitochondrial antibody. That's our test for PBC. Anti-smooth muscle antibody is our test for autoimmune hepatitis. So PBC is a chronic cholestatic liver disease. We don't really know why people get it. It's found found in all races, and most patients are female. 90 to 95% are female. Onset of age, it's kind of around menopause. So, thinking like 40 to 50 is a real typical age for this to show up. 95% have positive anti-mitochondrial antibodies. So this is really a testable piece of information for the boards. When they find blood tests that are 95% of people in a disease have it, they like to ask about it. The other thing is all the other autoimmune diseases that will be associated with it, typical thyroid, rheumatoid arthritis, Sjogren's, scleroderma, CREST. This patient had Sjogren's. She also had thyroid disease. That's a typical thing to have one or more other autoimmune diseases. A few more PBC pearls. Cholesterol is elevated in over half of PBC patients, and patients who have PBC are not at risk of higher risk for atherosclerosis despite their markedly elevated cholesterol. Most of this is secondary to a high HDL, and they generally have low lipoprotein A levels. So even though they might have cholesterols in the 300 range, they are not at higher risk for atherosclerosis. Treatment options, ursodiol can slightly prolong the time before transplant. It also may help a little bit with their itching. So we put most of these patients on ursodiol, but the most important thing we can do is transplant them. Complications, itching. Again, we have the same list of marginally effective things: cholestyramine, naltrexone, naloxone, ursodiol. Osteoporosis is very common in people with PBC, so screening for that, getting them supplemental calcium and vitamin D, and getting them on bisphosphonates. They get fat-soluble vitamin deficiencies, so we get them on vitamins. They also develop varices, so we need to do appropriate prevention there if their varices warrant them. 37-year-old woman is brought in with a history of alcoholism to the ED by friends with confusion and abdominal pain. Her friends report that she's been saying she's had right-sided chest pain for the last 6 days. Her friends last saw her 2 days ago. On exam, she is confused and drowsy. She has right upper quadrant tenderness, labs, white count 13,000, bilirubin 9, AST 10,000, ALT 7,000, INR is 8. So friends bring in this patient who's confused with abdominal pain, right-sided chest pain for the last 6 days before that. That's all the history they can get. The patient can't tell you anything. They're pretty out of it, except that they grimace when you press in the right upper quadrant. White counts 13, Billy 9, AST 10, ALT 7, INR of 8. What is the most likely cause of her symptoms? Impacted stone in the common bile duct, hepatitis C, alcoholic hepatitis, acetaminophen overdose, or hepatocellular carcinoma. So the right answer here is acetaminophen overdose. And this may have been an unintentional one. She had chest pain 6 days ago, and she may have been taking like, a couple of grams of Tylenol 4 times a day, 3 or 4 times a day, and then over time had an overdose. So when you see that level of transaminase elevation, always think about acetaminophen overdose at the top of your list, either intentional or unintentional. So when we see massively elevated transaminases, drug or toxin, acetaminophen is number 1, 2, and 3 on the drug list. As far as toxins, toxic mushrooms, certainly we have them in the Northwest. Have seen a few cases over the years admitted to the UW when people have eaten the wrong mushrooms. Acute hepatitis A or B, but not C. C does not really raise transaminases anywhere near as high as A can. And then ischemia certainly can do it. Dead liver, ischemic liver that you see after long surgery sometimes. Some of the less common ones, really sort of rampant autoimmune hepatitis rarely can cause massive elevations. Biliary early on can sometimes cause massive elevations, and then acute fatty liver, pregnancy, and HELP syndrome. But the main ones are going to be acetaminophen number one. Is it A or B virus? Usually A, or ischemia. A 47-year-old woman presents her evaluation of abnormal liver tests. She had liver tests done for a life insurance exam. I think we've already done this one, so we'll skip that one. So we're going to finish up here with just some board reflexes that I want you to think about. Um, Inflammatory bowel disease history and jaundice or an increased alk phos, I want you thinking PSC, especially if it's in a middle-aged woman. Middle-aged woman with, inflammatory bowel disease history and jaundice, especially in a man with increased alk phos, PSC. Okay, so 90% men there. So that's a common one. Middle-aged women with increased alk phosphoritis, PBC, 95% women there. So middle-aged men with jaundice and alk phos, PSC, especially if they have inflammatory bowel disease. Middle-aged women with increased alk phos, PBC. Antimitochondrial antibody elevated most commonly in people with PBC. So that's our test for PBC. Anti-smooth muscle antibody is most commonly elevated in individuals with autoimmune hepatitis. Also remember these people also, almost 100% of them have hypergammaglobulinemia. Weird hand arthritis involving the MCP joints and liver abnormalities. Think about hemochromatosis. Okay, well, we'll have a nice long break here. Why don't we take a half-hour break? We're going to start again at 3:15, and we're going to talk about some common symptoms. So we'll go from rare liver disease to common things you see every day. And I'm happy if people have questions, we can stick around a little bit of time here. We have plenty of time for questions.
Doug, I don't know if you wanted to, this is Rachel, just to reiterate, there had been a comment and just to make clear about the recommendations for ultrasound plus or minus AFP, if you wanted to just summarize that recommendation.
Yeah, so I think the most important thing on that is not to go with an alpha fetoprotein by itself. Many years ago, that was recommended as equal to ultrasound. And then more current recommendations say ultrasound is really crucial to try to do every 6-month ultrasounds plus or minus an alpha fetoprotein. Any other questions people have? Okay, well, we'll see you back here at 3:15.
Thanks, Doug. We'll see you in a bit.